Okay. All right. Hello. Yeah. So I welcome everybody who has joined us online and offline today for this webinar on medical legal aspects of surgery. And I thank our HOD sir for his cooperation and constant support for academic activities in our department. And I also especially thank our speaker today, Dr. Debrishi Gupta, for taking time off from his work and giving us his valuable insights into the medical legal aspects of surgery. So I would like to give a brief introduction about our speaker today. So I'll just share a slide. As I thought better for all the departments if they can. Their department I have informed them because it is a normal topic. I informed them. All right. So to speak, just give an introduction to our speaker today. He is Dr. Debrishi Gupta. He is a consultant and current of nursing home in Dhanbad, Jharkhand. So he is joining us live from Jharkhand today. And he is a consultant gynecologist there. And I think he is the head of the medical legal committee in Dhanbad Society of Obstetrics and Gynecology. And his key interests are the medical legal studies, high-risk cases, and critical care obstetrics, etc. And apart from all this, he is also a very good friend of mine. And I'm very thankful today that he has taken his time off from his work and giving us his valuable knowledge. Thank you very much, Dr. Debrishi. So, yeah, you can, the stage is yours. If you want, you can share your screen.
Yes. Am I audible?
Yeah, you're audible.
All right. I'll start sharing my screen now.
Sure.
Is it visible?
Yes, I will just make it full screen. Yes. I think you can use the presenter view or speaker view.
Dr. Ganesh, you're not very clear. I can't hear properly.
Okay. The presenter view or speaker view, you have the speaker view?
Yeah, speaker view. All right. So I'll start. So a very good morning to all of you watching. I thank you for taking time out of your busy schedule, that too in a work day, to attend today's program. I am truly humbled and honored to have been invited by ESI Medical College and Hospital, Bengaluru, to speak today. At the outset, I would like to thank the Department of Surgery, HOD Dr. Arun Kumar Uttam sir, and Dean Dr. Sandhya ma'am, and convener and my dear friend Dr. Ganesh Hegde for this opportunity. I will discuss about the two main weapons needed in medical legal defense that we must all know about. As doctors, regardless of the subject of our medical practice and institutions where we work, we must be clear about these concepts so that we can pursue a safe and tension-free career and thereby avoid litigations as far as possible. we can no longer be ignorant about law. So I practiced in the region of Chirkunda in Dhanbad, Jharkhand, which is a semi-rural area. I got interested in exploring law related to medicine practice when soon after passing out from college, I myself faced a unruly mob in a case of assault between two groups of people, which took an ugly turn, and I received a police notice of inquiry. So just fresh out of college, if you receive that, is going to really ruffle up everything. So it was then that I discovered that life outside medical college and shelter of a government hospital is quite different. Medical legal cases in our country are most often filed in situations of death of the patient, feeling dissatisfied due to unrealistic expectations, to escape out of paying hospital bills by alleging negligence, and also often on instigation by so called well wishers, business rivals, and political involvement. So, before we get into the topic proper, there are few tips to protect yourself right from the beginning. That is, to identify the gaps in your medical training. Many a time, certain areas might be gray areas in your learning and teaching. So, those are the things you need to work on first. Stay updated with respect to medical laws and standard treatment protocols by the government and expert medical bodies. Do something which is known as a self medical audit of the place where you work. That is, check the working condition and servicing of medical equipments you use, maintain a record for that. Train your nurses in specific management of medical scenarios and do mock drills so that they are always prepared in case any kind of emergency creeps up. Form a policy for necessary emergency drugs, and after discussion with your peers, your colleagues, and team members, so form a written policy about things you're going to use. Also, there's something known as an instrument policy. So, basically, a written way what type of instruments you're going to use for what kind of surgery. So, make a instrument policy like that. Something which is very important is an autoclave and fumigation record. How often are the things being autoclaved? That should be maintained in a record. Of course, in medical colleges, these are already done. But when you are working in private sector, you have to ensure that these are being maintained, even if you do not own the nursing home or hospital yourself. So know completely about the drugs you prescribe and their listed indications. Don't use any drug that you feel like wherever you want. Create a committee in your society or in your hospital to advise on medical legal issues. Identify an appropriate lawyer beforehand, not when a litigation is taking place. That time you go running here and there to look for a lawyer. So choose and identify a lawyer who deals with such stuff. Know your legal rights. This is very important so that you're not scared when there is any kind of mob or any kind of police pressure. Nothing. You are always confident about what you're doing. Organize CME WhatsApp group discussions also, so you stay updated with cases that are going around in your state or in the country. Sit down your Sit down and create your own treatment policy after extensive research of national and international guidelines. Our treatment protocols keep on changing because there's a lot of research work and recommendations being given everywhere on almost a daily basis. So keep updating the way you're practicing. Now, whenever you face trouble, dial 100 instead of calling your local thana. So, dial 100 is these calls are digitally recorded and transcribed, and local PCR unit or Hoysala has to respond within 15 minutes. This is better than calling your local thana directly because they have to respond when you call 100 number. So, medical legal help, where can you seek help? So there are dedicated organizations. I've given few examples here. One is Indian Medical Legal and Ethics Association. It is based in Amravati, headed by Dr. Satish Tiwari sir. It is an organization where you get updates about these things, and also they have team of lawyers and doctors who deal with such stuff. And there is IMA Medical Legal Cell in New Delhi. It can be approached via your local Indian Medical Association branch. Also, when you take up something which is known as a professional indemnity insurance, this can be either a personal one, that is a professional one, or it can be for establishments. So, in both these cases, these companies have a group of lawyers to help you and guide you in such cases in the first place. Then dealing with negligence cases. So first and foremost is effective and good communication. You have to speak properly to the patient and the attenders. So if you brief them on what is happening, however serious the condition is in the first place, they they know what is the condition of the patient, current condition, and so hence that usually avoids any kind of litigation. So communication is very essential. If there is an unfortunate death, you have to retrospect and think why and what went wrong. So have discussion among your peers to identify, if possible, a cause, and if clinically it could have been managed differently. So it will help you to learn and grow clinically, basically. So have a professional indemnity insurance of sufficient amount, minimum 20 lakhs. So in case there is any case against you, and unfortunately if you lose the case, the insurance amount which you have paid, that will help you to sort of buffer the losses. So how do you defend the case? The two main weapons are consent and documentation. So first we'll start with consent and its importance. Consent is not merely a formality or a piece of paper. It is our main weapon of defense in a court battle. Consent.
Hello?
Hello.
Sorry, Dr. Gupta,
Yeah.
sorry to disturb. Um, I just wanted to ask one thing that since since there are a lot of topics or subjects which might be new to many of people attending
Dr.
today.
Ganesh, you're not audible. Not very clear.
Hello? Can you hear me now?
Yeah.
Can you hear me now?
Yeah. Yeah.
Yeah. So I just wanted to know if after this topic, if we can have a session of for clearing doubts, like
Yeah.
after
Yeah. Definitely. Definitely. This is
after
the
one
first segment. After the consent segment, you can ask any doubts that you have. Any doubts at all. All right.
because all of these are probably skimming through the surface of the topics, and there might be some doubts from the audience.
Yeah. Sure.
Like,
Sure.
okay,
Definitely. All right. So, coming back, so consent occurs when one person voluntarily agrees to the proposal or desire of another. In medical law, consent commonly refers to informed consent, which gives legal right to the patient to make knowledge-based decisions about the course of their medical care. So, how does consent protect us? There are four laws in our Indian legal system which protects us doctors. These are mainly four things. This you should note down because quite a few lawyers are even not aware of this, and they do not utilize and help the doctors when they are facing a litigation. So, the first thing is Section 25, then is Section 26, 27, and 30. So previously it was Indian Penal Code IPC. This was known as Section 87, 88, 89, and 92. It has been renamed and renumbered. So BNS, Bharatiya Nyaya Samhita, is Section 25, 26, 27, and 30. So a valid consent gives you legal protection. An invalid consent gives you no protection. So provisions in the Indian law allow us doctors to do harm, that is surgery or treatment, only if certain provisions are fulfilled. So the act of taking a valid consent from a person and then starting a procedure protects us from any kind of persecution. Section 25 says that an act not intended and not known to likely cause death or grievous hurt done by consent is valid. Similarly, Section 26 says that an act not intended to cause death done by consent in good faith for the person's benefit. So, you are doing a surgery, you are not intending to cause death. So, if you have done it in consent in good faith for the person's benefit, then that is covered in this section. Then the last two are Section 27. So, an act done in good faith for the benefit of a child or an insane person, that is, these are for people who are not able to give consent themselves. I'll come to this later on. So, for a child or an insane person, whenever the consent is given by another person, that is a guardian or a parent, so that consent is also accepted. Then, Section 30 is an act done in good faith for a person without consent is not an offense. This is for cases which are emergencies. So in an emergency, person is not able to give consent, knowing that if you do not intervene, the person may die. So there you have not taken a consent and still you have gone ahead with a surgery or treatment. So that is once again covered by this law. So these four laws are very essential for us. Now, coming to types of consent, these all you might have gone through during forensic classes in MBBS. So, to summarize, there are mainly five types of consent: implied, express, blanket, consent by proxy, and informed consent. Informed consent is the main thing that we are concerned about. So, in brief, implied consent means consent given automatically by patient by virtue of action. So, that is when a patient is approaching a doctor for consultation in the OPD, it implies his or her willingness to be examined by the doctor. So that includes clinical examination, including pelvic and rectal examination. So if you're a male doctor and you're examining a female patient, there has to be a female chaperone, that is an assistant or a nurse present with you. Now, expressed consent. Consent given when a patient states expressly in clear terms, orally or written, to a request made by the doctor. So you are saying that you should go ahead and do this. So when the person says that, all right, I agree, doctor. So that is an express consent. The person is expressing. However, such oral consents are risky as it may be later on retracted. They may say later on, no, I did not say any such thing. So this was a particular case, M. Arunachala versus Dr. N. Gopal Krishna. In this, what happened was patient and her relatives alleged not having given written consent. However, the doctor had noted the express consent on the paper. That's why he got saved. So it is a very risky form of consent. Now, blanket consent is consent obtained stating that the patient is willing to undergo any type of treatment or including surgeries without mentioning what particular procedure or surgery. So this kind of consent has got no legal validity as it does not mention the specific procedure or complications. Then is consent by proxy. This is obtained when an adult person gives consent for a patient who is unable to give consent. So that is only valid for a minor, for an unconscious patient, and a medically insane person. It is not legally valid if the person is a conscious adult and able to give consent. So a person is an adult and he or she is awake. So in that case, if you're taking it from the husband or mother or some relative, then it is an invalid consent. The patient herself or himself has to give consent. Many of us are still not aware of this fact and usually take consent from the family members. Now, the main thing is informed consent. So there is a small ribbon at the top, legal prerequisite. What is this? So in this type of consent, it is where a conscious adult person of sound mind has the legal right to decide whether or not to submit a particular course of treatment after having been given been informed about the advantages, disadvantages, benefits, risk, prognosis, expenditure, and chances of success or failure. So basically, complete information has been given. So what all constitute a valid consent? It should be specific and separate for each procedure. It should be voluntarily given, that is, without any coercion or intimidating. You're scaring the patient, you're scolding the patient. That is not a voluntarily given consent. It should be taken in the presence of a witness. There has to be a witness. Consent obtained by fraud, mistake, or misrepresentation is also not a valid consent. Should be preferably in native language to avoid the legal lacuna. So if your forms are in English and they are signing in Kannada, later on they say that, sir, I did not understand. So to avoid that, it should be in dual languages. So English as well as Kannada. If patient and family members are illiterate, what do you do then? So you have to call upon a neutral witness who is not unrelated, maybe the next patient who is in the next bed, or any person in the hospital. That person can be a neutral witness to understand and stand as a witness for that consent. Now, in such cases, you have to take the left thumb impression and preferably you record a video of the counseling and the consent process. So later on, they can say that I did not understand what the doctor said. So to avoid that, it's better to record a video of that session in such cases. Now, a patient undergoing two separate procedures needs to give consent for each operation. So, for example, cholecystectomy and appendectomy in one patient, if it's so, you have to take separate consent for these. Now, there is a concept known as advance directive. In this, what happens is when the patient is under, that is, patient is anesthetized. Supposing you have you find something and you need to extend the scope of the surgery, technically you're not allowed to do that. So if a person gives a sort of a power of attorney, it's not a power of attorney in this case, it's known as an advance directive, stating that so and so person is being given authority by me to take decisions on my behalf when I'm incapacitated, that is, when I'm under anesthesia. So a legal representative is set up by the person beforehand itself. Since 2013, it has become a legal requirement to document video recording of the consent for transplant surgeries, not for other surgeries, but we can incorporate this. Quite a few centers have started doing this just to be on the safer side. So, what all is an invalid consent? So, anything that is obtained by, hello?
Yes, yes, you're audible. You're audible.
Yeah, yeah. Anything that is obtained by misrepresentation as to the nature of the procedure by fraud or mistake, that is an invalid consent. So once again, when a patient is under sedation, that consent is not considered valid. Failure in giving proper information or sufficient disclosure of facts, that is also not valid. If it's a minor, if it's a person who is mentally handicapped or of unsound mind, that is not valid. Procedure performed is substantially different or exceeds the scope of the surgery, that also is not valid. And most importantly, if a different doctor carries out the procedure than the one to whom it was given for, that too is an invalid. So, especially team based practices, such as in your college, there's a team which is carrying out. So, you do not know beforehand which surgeon is going to do. So, in such cases, the name of the team is written. So, basically, any member of that particular team, let's say you may be having it unit wise. So, unit A's doctors are being authorized to give surgery for that particular patient. It can be any member of that, but a different unit member does not get that same privilege. So it has to be mentioned beforehand. So in which cases are consent not required? You remember the last BNS which I stated. So that is basically covered under this. In an emergency situation, that is an accident victim, or if the person is insane, unconscious, or delirious person. So in any emergency situation, you can go ahead and carry out the treatment without consent. If the surgery is life saving, that then too consent is not required. If it is a notifiable disease, you do not need consent to notify your government nodal officers or district health authorities. You do not need patient's consent to give information when it is a notifiable disease. When the court orders a psychiatric evaluation or treatment, then too consent is not required from the patient. Now, in sexual offences cases, that is section 53 CRPC amended to 53A now. So when there is a police request to examine a person, in that case also consent is not required from the accused. You can go ahead and take samples as well without any consent. So what is a full disclosure then? So when you discuss and disclose all the details about the conditions, benefits, risk, investigation, everything, that is known as a full disclosure. But quite often we find that so much of information frightens the patient. So it might be practically difficult to divulge, but nowadays it is legally required, as this usually forms the basis of all the litigations, and they state that certain facts were not disclosed, that okay, so much risk was involved. So to be on the safe side, it is better to, at least in writing, it should be there. Now, there was a concept which was known as specialized privilege. So, doctors had the privilege to withhold certain information which could be emotionally or psychologically disturbing to the patient. But in view of so many litigations and verdicts, it is better to at least involve a close relative and tell them about the actual thing. So, basically, the complete disclosure you give to the attender, so they are in the loop. So they cannot say that I did not know that such and such risk was there. You can basically modify this specialized privilege minus the patient. So I have uh, hello.
Yes, yes, you are audible.
So here I'm going to give an example of a particular consent form. Although this is for a cesarean section, the reason why I picked this is because cesarean section is very unique situation where there are two lives involved, and multiple medical and surgical risks are obviously involved in such a patient. So whenever a consent is being designed, there are certain key things. So you remember in the previous slides, I had mentioned something known as a legal prerequisite. So this is what is a legal prerequisite. Can you see the pointer?
Yeah, yeah.
Okay. So the first arrow, if you follow, I so and so, blah blah blah, in a sound mind without any persuasion, influence, coercion, or pressure from any corner. So this sound mind without being persuaded, influenced, or coerced, this is the legal prerequisite. This is a self declaration by the patient. So this is the legal prerequisite. Now, in any surgery, the associated risks you have to mention in the consent itself. Also, if there are serious complications involved, like such as in LSCS, there are bleeding events can occur. There might be amniotic fluid embolism, perforations also, unknown perforations can occur. And if you are in a rural area, if there is a need to shift to a different center, tertiary level care. So all these things you have to pre-inform them. If certain life-saving steps are required, such as CPR, blood transfusion, in our cesarean cases, we sometimes may need to do hysterectomy at the same step if it is not manageable, if there is absolute catastrophic PPH, nothing is being helped. So, further, you're exceeding the scope of the surgery here. So, if these things are mentioned in the consent form itself, you inform the patient beforehand. So, there the litigation aspect is minimized or almost absent. Now, supposing you're in a rural setup where there is no blood bank in that area, so you have to inform them that, all right, I do not have a blood bank. Okay, there is no ICU facility in this zone, in this village area. So these all things also you have to mention. Don't expect that they already knew from beforehand. You have to mention it in the consent, and taking the signature, you proceed ahead. And this is a very important point. Medicine is not an exact science, and understand that there are no guarantees which can be given. So if you write this line, you are legally protected from the courts automatically. Now, I mention about indications. We are all doing various kinds of surgeries. Whenever you are writing indications, it should be something which you can refer to from a textbook. Don't make up your own indications. It should be, indications must be as per acceptable standards. Then a pre-anesthetic evaluation form. So there are many nursing homes and smaller establishments where you may work after this, which do not have a PAE form at all. I have seen this in many centers. So basically, anesthetist just assesses and proceeds with the case directly. There is no proper documentation. So in such cases, you have to, you should have a basic PAE form at least. This includes the basic information.
Sorry,
Yeah,
sorry
yeah,
about that.
yeah, yeah. So this includes a basic information and medical history. I'll just zoom in. Yeah. So a brief. Yeah. Okay. So a brief history about the patient, the medical history, and the basic information, and then comes the vitals and basic investigations. Now you'll notice this is like very little investigation that is mentioned. So this does not mean that this is all that you do. You can go and investigate more if required to your particular case, but this is the minimum that is needed for any kind of surgery. You'll notice here prothrombin time and APTT is also mentioned. I'll tell you why later on. So, and then anesthetic, pre-anesthetic preparation, what all were done, for what kind of anesthesia, whether it was informed, whether you took consent. and basic bathing, nail polish removement, xylocaine test dose, these things, that is the anesthetic aspect, all this should be there in the PAE form itself. And specific examination which an anesthetist does, nose patency test, oral cavity, teeth, malampatti grading, and how the mouth opening is there, whether there are dentures and all, neck extension. What is most important is the ASA PS risk stratification. This has to be mentioned. This is basically a risk stratification score which is designed by ASA, and there, after assessment of all this, they give a grading of the thing. So this kind of scoring is recommended by the ASA as well. So this is a basic PAE form. Your forms can be more extensive, but this is what is minimum required. Now, this is a photo of a machine that measures prothrombin time and APTT. These are point of care machines. Uh, you can just take a drop of blood and get readings of this. The reason why I'm showing this, you'll see there's something written. Veljibai versus VS Hospital, Gujarat State Commission, July 2021. A particular case was filed in which there were three allegations: negligence and deficiency of service, because PT-INR test was not done. So it's in quite a few centers, this is not done. Just BTCT is done, and that's enough. So there, you see, judges are not medical men. So whatever they see in a textbook, they take that as a standard. They do not consider the little minor variations as well. So what they said was PTRNR test was not done, doctor is negligent. So because this ruling is there, this has become a legal precedence now. So whenever there is a ruling to do a particular test, or a test was not done and a ruling was made in that effect, so that automatically becomes a requisite. So henceforth, we all have to at least do a PTRNR test. You can either do it in a regular lab if it is there in your hospital, or if you're working in a smaller center, you can at least go ahead and buy these point of care machines. These do not require the signature of a pathologist, because these are bedside tests, and in any kind of critical care, you do not need a additional signature. This is continuous monitoring systems. So next we come to something known as refusal of consent. So competent adult is legally entitled to reject a specific treatment or all treatments, even if the decision may lead to risk or even death. So in a case where doctor states in defense that consent was not given to me, he must prove the absence of consent. So when a consent is not being given, the consequences should be explained to them in the presence of a witness. This is most important. And a document known as a refusal document, or a negative consent, some places it is known as, should be signed. If the patient or relatives refuse to sign that document as well, then you can call once again a neutral witness and take the signature that I had explained such and such to this party and the relatives and the patient, and they are not agreeing to the treatment, as well as they are not agreeing to signing the refusal document also. In such cases, you are at the liberty to refer the case elsewhere. And refusal is not merely the absence of consent. It is a positive declaration of the unwillingness to undergo the surgery. So you put the burden of proof on the patient itself that I am not willing to take this treatment. So this was the case in Mr. Shakil versus Dr. P. Irani. What happened here was the doctor documented the refusal of consent. This was a patient who doctor had advised that you need to undergo a LSCS. Patient insisted that no, I'll wait for my father-in-law. Uh, because of the delay, the baby came out hypoxic and there was HIE. And then they claimed negligence. Doctor did not take care, and because of negligence, the baby was in such a serious condition and like this. Because he had documented the refusal on paper, that's why they could not call it a negligence case. So just one paper like this saved the doctor. So this is an example of a refusal consent. Here, what I stated just now, you have to mention that the condition or the treatment is necessary or urgently needed. So what treatment you have to mention over there. And here too, again, legal prerequisite: sound mind without any persuasion, influence, coercion or pressure. with that, I'm refusing to give the consent for the above mentioned procedure, and put the burden on them that I understand that my condition will worsen at any time as a result of refusing permission, and however, I'm still refusing, and you are putting the legal responsibility on them for any complication, untoward outcome, or death. So put the burden on them itself. So basically, declaration of seriousness of the condition, legal prerequisite, and also the burden on the patient itself. So commonly, uh, how many kinds of consent form are you going to design? A department of surgery is doing so many wide variety of cases. So what you can do is you can club the cases based on the system wise. Commonly, you all are doing cholecystectomy, appendectomy, hernioplasty, varicose stripping, bowel surgeries, anal surgeries, circumcision, excisions, IND. So for the commonest surgeries, which are almost on a daily basis or quite often, for those you can design separate consent forms, and whatever is outside the usual practice, that all you can write it as and when required. So if these forms are pre-designed, like in my center, we use printed forms. In that, at the end, we make them write one line in their own handwriting. So that itself is all right, acceptable to court. Previously, we used to think that the entire consent form should be handwritten, but there have been legal rulings about this, and so currently, the mm, the whole precedence is that you can go ahead and use printed forms, and it should be specific to the condition that you're stating, not a general form. So whenever a person is leaving against a medical advice, so in such cases, once again, you have to put the burden on them again. So here you have to state that my patient is sick and medically unfit. In spite of that, I am taking responsibility and exiting the institute, or I'm maybe taking him home, or whatever it might be. That is my choice. So my patient's responsibility I'm taking, and I'm not following the doctor's advice. So against advice I'm taking. So a DAMA form, you just don't merely write that patient went DAMA, not like that. It should be a form that is signed by the patient's relative, because at that moment the patient is not properly fit enough to understand and sign. So DAMA form you have to take properly. Now, the key points when you're designing your consent is all the criteria that we discussed. So advisable to make the form in two languages, English and native language. Get the signatures on both form. All the forms that you design must have certain key contents, that is basic identity. Form is being sound with the legal prerequisite, sound mind without any persuasion, influence, coercion, or pressure, and mention of additional possible deviations, like supposing you are doing a particular procedure, there may be certain known deviations, so that also you mention, and mention the scope of the treatment. What are you doing this for? Why are you doing it? Known common complications, rare complications, including death. That too you mentioned. There's no need to hide that fact that, okay, unfortunately, death might occur. Mention that as well. Setup based limitations you mentioned. And the most important thing is declare that medical science and treatment is not an exact science. Signature or a left thumb impression of the patient and one relative, or even if it is not a relative, a witness who is there with the patient. So this is the summary. Dual language, basic identity, legal prerequisite, complications, possible deviations, and center-based limitations. Our organization, Gynae organization, which is called as Foxy, you might be have heard of it. So Foxy has designed a booklet which is freely available on its website. It is based for gynae practices, but you can get an idea. Most of the forms are about 4 or 5 pages long, where there is definition for each thing. You do not need to have such an extensive form. You can make the form as you want, but clearly state all the points that we just discussed. Do not omit the complications or conditions, even if they are rare, and make forms which are specific to your center of practices, whether it is private practice or clinic or a medical college, design forms which is specific to your capabilities. So there are no ideal consent forms. You have to design your own forms, which is helpful. Opposite lawyer will always try to find faults with your consent forms and in the hope of proving you negligent. So if you follow all the rules that we discussed and design your forms in an ironclad manner, you can always defend yourself confidently. Court only and always accepts documentary proof, nothing else. I said this, I told them this, that all doesn't matter. So this is the first segment.
Okay. So before this, should I check if anybody
If there are any doubts at this point, then
anybody wants to ask?
we can take up a few questions now.
Hmm? Okay. Yes, sir. I will just tell you what you are there any cases when you have operated on emergency without any consent, as patient was not able to consent. So if there is on table then and the latest comes later. So are there any cases like this? Dr. Gupta, can you hear me now?
No, it's not audible.
Hello, can you hear me?
Yeah, you take the mic a little bit away.
Okay. What about
Yeah.
now? Yeah. So our doctor is asking that in a situation where
It's not audible, Ganesh.
okay. How about now?
Yeah,
How
yeah,
is
much
it?
better.
Yeah. So if we have operated on a patient.
Come to the front. It's the voice is getting cut.
Okay. Okay. In an emergency,
Yeah.
when you have operated on a patient in an emergency situation without a consent, but the patient dies on table,
Hmm.
and the after that there is an issue and the attenders are causing trouble.
Hmm.
So, are there any situations that you have seen such situations where
Yeah. So whenever there is death, obviously you can expect trouble, right? Obviously. So emotions are involved, and whenever they come to a hospital and doctor, they expect you to be in the role of a god. So, but medical limitations and such situations, everything, obviously, we will obviously try our best, but then death can occur due to very many reasons. So, if you are doing something to save the person's life, and despite that the person is dying, whether it is on table, off table, in the ward, that is regardless. If there is death during the course of treatment, remember these four laws are the ones which will protect you. So case in point is if uh, according to section 30 BNS. So if you are doing something for the benefit of the person without a consent, it is not an offense. Even if there is death, knowing that okay, such and such surgery may save him or harm him. For example, a burst appendix. You know the person, if diagnosed in time that it is burst appendix, there is no attender. You go ahead and do the surgery. You are protected by section 30, but you have to be proper in your documentation. You have to give the proof that yes, there was burst appendix, you diagnosed before surgery. In table, you can take a photograph with a timestamp, or if you have a video facility, some domes have got video facility, that too you can go ahead and take. So now, after the death, you have informed the police that so and so patient had come without an attender. I took consent to do an emergency surgery. Unfortunately, on table the person died. So the police has been informed. 2 days later, their relatives turn up with a huge mob and they are doing a lot of galata, fighting with you. So there, what happens is you have informed the police. Number one, now they go ahead and say that no, we will go to court. In the court, you are again protected by section 30. This gives you a protection, but there you have to prove that yes, this was an emergency, patient was critical, and what you did was for the benefit. It is an established medical practice to do an urgent emergency surgery to try and save the life of the person. So that, I think, does that clear your doubt?
yeah, Dr.
Okay.
Debrishi. And regarding video recording of consents that
Hmm.
nowadays many institutions follow.
Yeah.
So, what is the current stance on video consent, and in comparison to the normally written, or sorry, the printed or written consent, is video consent considered better?
That is not an alternate. That is technically for our own safety. Because counseling process you cannot record on paper, right? How extensive will you write? So if you go through the booklet, Foxy booklet, in there the consent forms are 4 pages. There they have explained everything about childbirth, about LSCS, about normal delivery, about neonatal complications, one line definitions for everything. So that is the American system basically, where extensively everything is discussed in the form, and last 2 pages are the signing signature section. So, but so much of paper nobody is going to read. Imagine 5 pages for LSCS, 5 pages for anesthesia. So 10 to 15 pages on an average just for one procedure. Do you think they're going to read it? They might say, even the court will comment, you have given them almost a booklet to sign. How are they going to read? So there, everything is working against our favor, against doctors. So simplify and condense the form, give as much information as required. But the problem is you cannot document the counseling part, where you're sitting down with the patient and the relative and explaining that this is the condition, we need to do the surgery, this will give you this benefit. So where is the proof that you have explained all that? Written part is there, but in spite of that, if you take a video session of that, written has to be there. That is mandatory. Along with that, if you take a videography of the session, then you're doubly protected. So if they say that no, it was not explained, it was just they just told us to sign, you have proof that you explained everything, then you took the signature.
Anybody has any other doubts in consent? So, just one last doubt regarding taking photos and videos in the OT.
Yeah,
Uh, I have seen that many people include that in their consent.
yeah,
Is it
that's what I do.
compulsory or mandatory?
It is compulsory. See, previously the concept was that if you take a photograph of a patient, you have to cover their eyes and basic identifying features, and then you can utilize that photograph for journal purpose and all that. But the Privacy Act, the privacy laws, that has changed, and because of that, what has happened is you have to take consent for taking any video or recording. And see, I'll showing you a particular slide. There I've just mentioned one line. I give my consent for medical imagery or videography on condition of privacy and anonymity, which may be used for medical, scientific research or CME purpose only. So if they are all right with this, it's fine. If they say no, I do not give my consent, you can just straight away strike out this and write consent for videography, photography not given. There you cannot take, because most often what we are doing is we find an interesting case, we have taken a video, we're sharing it on WhatsApp with our colleagues, but that is not legally acceptable. If God forbid court finds out or the police finds out or the person itself finds out that, oh, my video of my surgery is being circulated everywhere, they can aram se do a case on you and you will be in real trouble, because you do not have the permission in the first place to do this. So just this one line is good enough.
Okay.
Any other questions?
Uh, Let me just check the chat box. Just 1 second. No, I think no questions. Chat.
Okay. All right. So now we'll come to the case segment. So these are specific cases, surgery cases especially. First thing that I'll talk about is something known as contradictory rulings. So sometimes you'll see, if you have ever come across any court cases in the newspaper and all, they are giving one particular order or ruling. And then after a few months, you read another case quite similar. There the order is totally different. Same case, in one they are saying that all right, this is what should have been done, and in another case they are saying the completely opposite thing. So this is known as contradictory ruling. This is quite common in our country, and it confuses everybody. That what should I follow? Is this right or is that right? So case in point, uh, Prashant S. Dhanaka versus Nizam Institute of Medical Science. This was 1999 case. Uh, this case was in the National Commission. So in this, what happened? That's one particular case. And the second case, which we consider as landmark case in our medical practice and law practice, that is Samira Kohli versus Dr. Prabha Manchanda. This was a Supreme Court case. So the first was P.S. Dhanaka case. Here, a consent was taken for excision biopsy via thoracotomy. So the doctor went ahead, did the biopsy, and closed up. They filed a case that why didn't you do the surgery at the same sitting? So the court said that you should have done the same surgery and doctor need not limit the operation to diagnostic purpose only. Could have proceeded for the curative step also instead of putting the patient for a resurgery. Very confusing. Now in Samira Kohli versus Dr. Prabha Manchanda case, here what happened was there was a 44-year-old unmarried lady. She had complaints of abnormal uterine bleeding. USG was done, multiple fibroids and chocolate cysts were found. Consent was taken for diagnostic and operative laparoscopy under GA, and that laparotomy may be needed. So this was the consent that was taken. So while the patient was unconscious during OT, they opened up and found that there was type 4 endometriosis, frozen pelvis basically. So there they proceeded for open laparotomy with this thing total abdominal hysterectomy with bilateral salpingo-oophorectomy. This is the established this thing guideline for such cases. So the surgeon sent the assistant outside and consent was taken from the patient's mother and they proceeded with the surgery. After surgery, the patient was informed about what had happened. Later, she went Dama without paying the hospital bills. So a legal notice was sent by the hospital people that you have not paid the bill and so and so. They filed a case that they did negligence and they increased the scope of the surgery to extort a higher amount, and also doctor was not qualified enough, etc., etc. So these are allegations which will creep up. They will call you not qualified. They will call you negligent. So these are things you have to defend. So in this case, the doctor lost the whole case. So very surprising and shocking. What happened was the court took out the textbook and read that what does consent for. You will remember the consent was only for exploratory laparotomy and laparotomy if required. So it was just a diagnostic, and they might do laparotomy and explore. So laparotomy by itself is not um, ATH with BSO by textbook definition. Laparotomy means that you're opening to cut open the abdomen by definition. So here consent for the ATH BSO was not there. This was point number one. Second thing where they lost was legal notice sent by the doctor was faulty. They had wrong facts. It stated that you were admitted for diagnostic and operative laparoscopy and endometrial biopsy. After conducting a laparoscopic examination, video recording of the lesion was shown to the patient's mother and the patient, and the doctor informed the patient and her mother that conservative surgery would be futile and ATH BSO is advised. This was the language which they had written in the legal notice to the patient. So here the court picked up that how could you inform the patient? Patient was already under anesthesia, so unconscious at that stage. So information could not have been given to her. So you're stating wrong facts. Third ruling was extension of surgery without consent is illegal. This is known as a legal term called battery. So unless it is life threatening, you cannot exceed the scope of the surgery. So judgment did not consider any of the expert opinion. AIMS team was there, and there were 2, 3 other expert bodies were there. They did not consider any of the expert opinions. They only saw the textbook definition, and the doctor lost. So just a small legal language was like this. Second case is Dr. T.T. Thomas versus Srimati Eliza and others, 1986. This was Kerala High Court. A male came with complaints of severe abdominal pain, was admitted to casualty at 3:30 p.m. It was diagnosed as a case of acute appendicitis. Diagnosis confirmed by the attending civil surgeon, and he advised urgent surgery. And with that advice, they shifted to the surgical ward for preparation. Now, court allegation was surgery was not performed on the day itself. Condition of the patient deteriorated the next day and led to death. Doctor would operate only if paid a bribe of 25 rupees. So this was back in 1986. 25 rupees was quite a lot. So doctor left the next day to work in a private nursing home and came back only after the death of the patient. So the case was not done on that day. This was a fact. It was next day the patient's condition deteriorated and the patient died. So these were the allegations. The counter which the doctor stated was, he stated that he diagnosed the case as a perforated appendix with peritonitis and he advised immediate operation. The no surgery was done on the patient on the day itself because of the reluctance of the patient to undergo a surgery, saying that he had similar attacks before and he used to get relief with injections and other medicine. This is quite commonly you might be facing. Patient is reluctant. They just say that, all right, no doctor, just give me some medicines and see, then you do the surgery. So that is why he went ahead with conservative treatment. But as the condition grew worse the next day, he was not in an operable condition and therefore the operation was not done. And the patient was then willing to be operated. When he became worse, he said that go ahead and do the operation. The doctor denied charges of bribe from the attenders. He also denied that he was absent from the hospital. Verdict was doctor was negligent on account of failure to perform the emergency surgery. So what were the legal observation in this case? Doctor should have operated on day one itself instead of waiting for consent, as a diagnosis of perforated appendix with peritonitis is a life-threatening emergency condition and hence does not require consent, as a surgery then would be done in an attempt to save the life, and provision for which is protected by law. Section 88. This was during IPC. So Section 88 has become BNS now. So what we learned, those four laws, this was specifically mentioned in this case. So you do not need consent in a life-threatening situation. You go ahead and do the surgery. Number one. Second was absence of consent was not proved by the doctor. Remember, refusal consent or negative consent, that was not there. So because it was not recorded, so the doctor could not prove that the patient had refused the consent. So these were 2 points by which the doctor lost. Next case is Jain Srivastav versus Ram Bihari Lal and others, 1980. This case actually took place in 1950, but the reason why I'm stating such an old case is because this basically highlights the concept of you cannot judge a case which was done few years back based on the facilities and things which you have now. You see, after so many years, this case was filed. It should not have been filed in the first place, but cases can be filed at any given time based on if the judge feels so. So that's why any case that you're doing, uh, till you're alive, you can expect it to come back and haunt you. So maintain all records for this. So this case is female with complaints of abdominal pain with occasional vomiting. Surgeon Dr. Srivastav was called for consultation and treatment. In those days, streptopenicillin injection was there, so he gave those and sedatives on day 1 and 2. Pain did not subside. Temperature started rising. There was extreme tenderness over the RIF, which had been throughout. DLC revealed 84% polymorphs. This confirmed doctor's tentative diagnosis of acute appendicitis and he advised appendectomy. This was back in the days when there was USG was not available freely. So just based on Mantle score he was doing. Husband consulted the district medical officer over phone, and the district medical officer said that since 48 hours had passed and pain had subsided, surgery is not needed and you can go ahead with conservative management. So this is something you might face. So and so doctor who is a family doctor of the relative is giving you a cross advice over the phone. So this is something you might face, or a senior doctor who is posted at the district level, who is senior to you, is giving you advice. That is not actually acceptable. If you need to give an advice on a case, you visit, see the patient, and then give the advice. Not give an advice on top of the treating surgeon or doctor. So continuing, the surgeon still insisted there on prompt appendectomy to prevent chances of perforation and peritonitis. So consent was given. During surgery, appendix was found to be normal, but the gallbladder was found to be acutely inflamed and full of stones. Hence, a second incision was made and cholecystectomy was done. Those days, chloroform was being used as the anesthetic drug. So, ethyl chloride induction maintained with chloroform, and there was no adverse reaction during surgery. She regained consciousness, asked for water. Progress was satisfactory till next day afternoon. Thereafter, her condition began to deteriorate. Lot of medical experts came in from all over at the request of the husband. Allegation was wrong diagnosis was there. Gallbladder was normal. Surgeon was incompetent and should have listened to the DMO's advice. Urine was not examined before surgery. Chloroform was contraindicated in this case. Hospital was not well equipped. Removing the gallbladder without consent of the husband. Willful disregard of the line of treatment suggested by medical experts. Patient had deteriorated because of overwhelming toxemia due to hepatorenal failure as a result of prolonged chloroform use. So many allegations were done in the court case. And you see, this was filed after 30 years. Patient had died, and as an afterthought, this was filed. So observations was, just because a misadventure or mishap happened, the hospital and the doctors cannot be held liable. This is point number one. Expert witness testify that clinical symptoms which were present could easily be mistaken for appendicitis. Also, acute abdomen was a condition which, if not attended within reasonable time, was likely to lead to serious consequences. There is absolutely no negligence in the diagnosis. A mistaken diagnosis is not necessarily a negligent diagnosis, nor would it imply an absence of reasonable skill and care on the part of the doctor. Some discretion must be left to the judgment of the doctor on the spot. No fault has been found with the surgery performed. The diseased gallbladder had been preserved in a jar and was produced in court. It was in a highly pathological condition. In order to save the life of the patient, the doctor felt cholecystectomy was necessary. The case sheet records consent of the patient's husband to the use of chloroform as anesthesia. It cannot be absolutely said that it was chloroform which was responsible for the hepatorenal failure. That is only a assumed probability. No postmortem was done, and cause of death was not tried to be found on the basis of scientific data. Operation performed was in 1958. Use of chloroform was in vogue that time. So you cannot judge matters in 1980 about things that were done in 22 years ago. Surgeon was making the best use of whatever facilities were being made, because in that district hospital he was performing almost 500 cases a year. So he was using whatever resources was there. Surgeon had followed a recognized practice and had shown reasonable carefulness and skill in performing the operation. Hence, he could not be made liable for damages for negligence. Case was dismissed, no negligence. So that is end of the surgical section. Dr. Ganesh?
Uh, yeah, Dr. Debrishi, since this is covering a lot of ground, consent, documentation, etc., do you think we should divide it into multiple sessions and do it on different
As you
days?
wish. I know this is a bit dry and very extensive.
Yeah,
It might put you to sleep as well. So
yeah,
that's why these two main segments. Last part is documentation. It is a very short segment, about 10
yeah,
minutes. If you want, I can
yeah,
do it,
yeah,
or
yeah, yeah.
we can do it
Yes, yes,
another day.
yeah, yeah. We'll cover then. We'll
So,
talk about documentation.
any doubts regarding the four cases, the common scenarios which you face every day, I guess?
Okay. So one doubt that I would want to ask you is that regarding mistaken diagnosis is not a negligent diagnosis.
Hello.
So,
Yeah. Regarding?
am I audible?
Yeah, yeah.
Yeah. So, mistaken diagnosis is not a negligent diagnosis.
Right.
So, is this acceptable in court? For example,
Hmm.
if we have a case of acute abdomen,
Hmm.
it has multiple differentials.
Hmm. Right.
So, common is appendicitis, could be pancreatitis, cholecystitis, all of these. So, in case we have a working diagnosis, which may later, after imaging, turn out to be something else.
Hmm.
So, and if you're treating for no for another diagnosis earlier,
Hmm.
later on, after the investigations come, you find out it's something else.
Hmm.
So, if there is any complication, are
Hmm.
you held legally responsible, or are you?
See,
Can you say that it is a mistaken diagnosis, so it is not a negligent diagnosis?
the well accepted legal uh, standard is, or the rule is, negligence is when you are not giving due care. Like supposing you are a MBBS doctor and certain level of care is expected from you. It does not mean a super specialist surgeon can do the case differently, or maybe he or she can diagnose the case more accurately using various other tools. But as an MBBS, if you're expected to do a certain level of diagnosis, have you done that or not? This is the first thing. So basically, you cannot measure two different experts who have got difference of experience in terms of years and say, because whenever there is a case or a negligence, an expert body is formed and they will say that no, it should have been done like this. But what has to be considered, what the court considers is minimum acceptable standard, whether it was followed or not. So the same concept applies in a case of mistaken diagnosis. In the textbook, if in Bailey it is there that so and so things are confusing and such conditions have differential diagnosis, your reference, the points that you're going to put across in your court paper, it should be that this is a known thing that uh, acute abdomen can be these things. So that should be mentioned in your differential diagnosis in your case sheet. If you have not mentioned, then that means you did not think in that way. So basically, whatever work you're doing, that has to be written in the case sheet. That is point number one. Later on, as you investigate and certain things have changed and the picture turns out to be something totally different, so it is an ongoing process. It does not mean that once you made a diagnosis and that diagnosis changed later on. So that does not mean negligence. So that is totally accepted in the court. But both these incidents, both these events should be there in the case sheet. That first you thought these things, why you thought, supporting points you have to write, and later on after certain evidences which you got, maybe CT, blood workup, and then you find that, oh, this is something else. So then you find that on basis of this thing, the diagnosis appears to be currently this thing.
Anybody else has anything to ask? Okay. One more question from my side. So, am I audible now?
Yeah, yeah, yeah.
Thing is, nowadays we operate a lot based on uh, ultrasound and CT reports. So, so we are sometimes, even though clinically, uh, sometimes it is not very evident, or clinically it is not very obvious,
Hmm.
and we do rely on these reports sometimes.
Hmm.
Let us say what we find in the reports and what we find intra-op is completely different.
Yes.
So, and then we have done the surgery. So in such cases, and we have taken a consent for something else. And so, what would you advise such situations?
So this dilemma is something we face quite often, especially in gynae practice. Certain such things are mentioned in the ultrasound, and we start jumping, patient starts jumping, and the attenders start jumping, and we go ahead and tell them we have to do this or that. Later on, when we open up, we find something totally different. So what are you going to do in such case? You are basing everything on the imagery, right? Now, the problem is if you only go based on clinical diagnosis, then the court says that why didn't you do an ultrasound? So, this is
Yeah.
the issue. You have to rely on your own experience clinically, but for the sake of documentation and legal protection, you have to take the help of the imagery. Now, supposing it is giving a different diagnosis, the thing is, once again, what I would suggest is communication. You communicate with the patient and the attender saying that, see, clinically I am suspecting this, but in the picture it is coming as this. So even in this, we are going to open up, but in case I find so and so things, it might be required to take this step. If you discuss properly as if the problem is your own, then the patient and the relatives appreciate this thing. So there you do not have any fear of litigation. They appreciate that, okay, the doctor is thinking on my behalf. So he or she is trying to solve my problem. So I have found in my practice, when I communicate and explain things to them, if I find something which is not at all coming in the clinical picture, in the clinical assessment, I tell them that although this report is saying this thing, but I am not finding features of this. So either you get a re-report done, because based on this I have to do this surgery. So they appreciate that, and quite often I found that another report at a different center reveals something totally different. So these are problems, human-based problems, which we do face, especially in a non-center-based practice. In a college, you have everything in the same place. You can again send it back to the radio department and tell them to take another glance. The problem is when you're working in a standalone center or in a private clinic. There, everything you have to think of. So this is what you should do. You should explain and discuss, and go ahead and taking this thing permission for a secondary step if required, if you do find. But explanation is essential. You have to explain nicely to the attender and take consent.
Yes, any questions? Yeah.
Patient from casualty was a corporation, a particular corporation case. We advise him surgery, but the patient has abandoned. There is no document. All our documents are with the patient. We just inform the CMO or the police.
So, Dr. Gupta, we have a question regarding a patient who has absconded, basically, who has absconded with the hospital documents, and there is there is no documentation which we have originally done. We don't have any evidence. So, what should be our course of action that time? As the patient is come for an emergency, like is in a critical state, he requires treatment but absconded. What should we do?
So, for example, he had come into the casualty, you had written something, and then you probably. So, are you asking about a operated case, or in general, supposing they visit the casualty and then they run away?
Yeah. Something like that.
Okay.
They have come to the casualty. We are, we have examined, done our investigations, etc. Probably we are planning a surgery or something. But next, we don't find the patient in the bedside anymore. So what should be? How do we
So,
notify, or whom do we notify?
so two scenarios here. Number one, if they have come, you have advised, and they ran away, but you have all the case sheets and everything with you. In such case, just fold it, put it in your bag, and go home. No need to inform anybody. Why? Because there is no proof that the person visited. Scene number two. If they have run away with the case sheet, immediately pick up the phone and call the police. That so and so person had come, I had suggested treatment, and he has absconded. Absconding is case number one. Patient is under your care and has run away. So that's absconding. In absconding, you have to immediately tell the police that so and so time, till so and so time, patient was there, then he ran away without permission. And number two is theft of hospital property. Is run away with the case sheet. Until and unless you hand over the case sheet or the discharge card to the person, that is your property. So that is theft of hospital property. So these are two scenes. If they have run away with the document and has run away without permission, immediately call the police and state the two things. He run away with the sheets, and also he is absconding. So police is informed. Police has to be informed immediately. Does,
So in the
hmm?
institution where we have a CMO,
Yeah.
we have a CMO, Chief Medical Officer. Uh, so I guess it implemented
So
the CMO and the
usually,
CMO.
casualty CMO has the responsibility to do these things. So that's why we are not aware what all have to be done. But the responsibility falls on you actually legally. Whether you have informed the police, you have informed your CMO because it is his job to handle all these events. But you have to ensure that the CMO in turn has informed the police. So you have to go and keep asking, sir, ma'am, have you informed? So make sure that it is informed. Regardless of who is calling up, that does not matter. So CMO will say that my so and so casualty doctor on duty saw this patient, the patient was advised this, and the patient ran away. Name and all that, we do not have any record because the papers have been stolen. That much information is given to the police, you are safe. And the reason why I said that put it in your bag and go home is because such a patient who has run away without taking treatment, put it in your bag means you don't have to literally put it in your bag. You can just put it aside, tell the CMO that, such a patient came and I told the treatment, but he ran away. So CMO is informed, and then you don't have to intimate the police in such a case because they have not taken the treatment as such. If it is, let's say, life threatening, I think she mentioned perforation, I think.
Yeah, yeah.
So, in a
Good point.
perforation case, the person might die on the road, right? So,
Yeah.
in such a life threatening situation, definitely inform the police. I saw the patient and then he ran away. We do not know what might happen. So, please be informed. Both
Through the
ways,
CMO. Through the
through
CMO.
through the CMO, but ensure that the CMO is following through and calling the police. Basically, one small statement is written by you. Whoever has seen that I saw so and so patient, male, female, age so and so approximately. Name I do not recall because the papers were stolen, and so was the condition. Hence, the police have been duly informed. Sign dates with time. That's it.
One
Yes.
more question.
Are there any cases registered on radiologists who have given wrong diagnosis because of which treatment was delayed or the surgery was not performed? For example, we had a case of Mr. Superior ventricular thrombosis. It was diagnosed as acute pancreatitis, because of which surgery was delayed.
Dr. Gupta, were you able to hear that?
Bits of it. Please repeat.
Okay. So, in a case where the radiological
You're
report.
not audible, Ganesh. Come a little bit to the front.
Okay. So, in a case of in a patient where the radiological report is wrong,
Hmm.
basically. Let us say a patient with superior mesenteric artery thrombosis
Hmm.
is diagnosed through CT scan as pancreatitis.
Right.
Okay, so it results in a delay in the treatment, actual treatment for the
Right.
patient.
Right.
So, is the radiologist held liable in
Yes.
court
Correct.
for
Correct.
this, or is the surgeon who is the treating surgeon liable? Yeah, I think that is the question.
It depends on basically the outcome of the case. If the patient dies, then they will try to also include you in the liability. That is known as joint and several liability. So here, what happens? The thought process is every headache and every responsibility is on the team leader, treating surgeon, treating doctor, whatever it may be. If you are the unit chief, it is your headache. If you are a single doctor, it is your headache. Regardless of what your position is, you will be responsible in a slight way. But here, if you can prove that I was working based on the diagnosis given on the radiology alone, because this could not be clinically diagnosed. You have to be very certain about the subject. So, if you state that, then the court may decide that, all right, this is not easy. It's not like appendicitis that you can directly diagnose. You need certain tools to diagnose this. In such a case, the court will singly hold responsible the radiology department or the radiologist who was doing. It does not easily. How do you ensure these things in such a case of an ambiguous diagnosis? Once again, documentation is your help. Over there, you have to state properly what was mentioned, what you opened and saw. Don't try to hide the facts or go around. And then again, with the person, you say that although this uh, was suspected, but in the radiology, this is there. And when I opened up, I found this.
All right. So what I'm getting it is that from what you said is that you have to prove to them that it was not possible,
Yes,
or it was not, there was no other differential possible clinically.
yes.
Hence, you went ahead with the radiological report,
Basis, yeah.
and yeah, and you treated the patient. Hence, that was the outcome. And
Yes,
so it is not on you. Basically,
yes,
you
correct.
cannot be held responsible.
So it's not only verbal. Verbal is definitely the most important step. But more than that, it should be written. What you explain to them, that you write as well. Take 5 minutes of your time and finish writing that. That I this was suspected, but on intra-op I found this, not that. Otherwise, you will be held responsible.
All right. One more doubt.
Yeah.
Okay. So regarding consent for procedures, do we specifically mention what type of anesthesia
Yes.
that we will be doing the procedure under, or is it the work of the anesthetist who will take their own separate consent?
They will definitely take their own separate consent. So remember,
One second, sorry. Is that the question? That is the question. Okay, okay. Yeah, Dr. Debrishi, please go ahead.
same question, right?
Yeah.
Yeah. So procedure consent is different, anesthesia consent is different. You cannot club the two together. This is understood. So the responsibility of taking the anesthesia consent is not that only the anesthetist is responsible. Any duty doctor, junior, senior, can explain to the patient regarding the anesthesia, the routes and all, and then that okay, the anesthetist will decide whether to give GA, spinal or regional. That's fine, but the explanation part has to be done by a doctor, and then the signature is taken. So this is step one for the anesthesia consent. Now in the surgical consent, whatever surgery you are taking, in that also you have to mention that whether and so procedure which may be undertaken under GA, spinal or regional as deemed fit by the anesthetist. So responsibility is his, but that is mentioned that you have basically what I'm trying to drive at is do not leave any scope for the opposite lawyer or the court to find a fault. Write everything everywhere so that they cannot hold you responsible. We understand that it is implied and it is their responsibility, but when there is a problem, blame game will start. So if it is properly written, just 2-3 words is enough to safeguard you. You have to protect your own self-interest and practice over here.
All right. So basically, we need not mention, what you're saying is we need not mention the type of anesthesia that the patient will undergo in our surgical consent.
Yes.
But if we do mention, you will have to write that GA or spinal or whatever as
Regional
deemed fit
anesthesia
by
as deemed fit by the anesthetist. It is not my responsibility. It is the anesthetist's responsibility. But here I am mentioning that this will be undertaken with anesthesia. That's it.
Okay. All right. So, okay. So, Debrishi,
Is
should
everybody
we?
hungry?
I mean, it is lunchtime, but since you said documentation is a very small part, I
It's
guess
a
we
short
can.
segment.
Yeah,
I won't go in depth. I'll just tell a
yeah,
few points.
yeah, yeah. I would
So, can you see the slide?
Yeah.
Yeah, okay. So process of storing facts and information in a structured manner, which can be retrieved at a later date, is documentation. So over here, yeah. So lot of verdicts in medical legal cases are in favor of the patient due to poor documentation and record keeping by us and the hospital. Even though you have put your heart and soul in treating and trying to save a person's life, we end up being harassed and eventually lose because we are unable to prove how much of dedication we did due to lack of proper documentation. So even though you may have scientifically and correctly treated, if you have not documented, it was never done. So concept of documentation is mainly three. It should be medico-legally correct. There should be proper preservation and right to access. That is, who is going to access it at a later date. So two types of documents are there. One is paper records, whatever we are writing, case sheets and all. And then there is computer records. So problem with paper records is they are huge, voluminous. They are taking up a lot of rooms and everything. And uh, computerized records is their software based, involve a lot of technical training, annual payment, software maintenance, virus attacks, glitches. If it is cloud based, network issues always hinder the work. So an easy way is to have a scanner with and a laptop or a basic computer, and is to scan the records at the end of the discharge and store them. So probably in a medical college, this may not seem relevant to you because there is an MRD usually. But whenever you're working in any other kind of center, you have to take care of your own records. So you can teach any of your staff. That is what I have done. Any and everybody knows how to scan and store these things. Just a normal scanner will do. All the pages that you have done, just scan and keep it. So computer records, they will help you to quickly retrieve it if there is records are asked for later on, and they are safe from physical wear and tear, rat infestations, and fire. So you can shift time to time to a DVD or a separate hard disk. So this is not how a OPD record should be written. So this is an example of how badly things can go. You have to write legibly. Court has time and again mentioned this, that doctors are not writing properly, and they have given warning and ruling against us quite sometimes. So OPD records, you have to write clearly. You can take a photo, even OPD records. If you are not aware, you should start doing this. Whatever case sheet you're writing in the OPD, at the end, take a photo on your phone. It just takes a minute, but you will be safe. Basic data is personal data. This is what we have studied in MBBS, the same format you have to follow. So it is a good idea to keep a pre-printed form of this so that it reduces the writing time, especially in busy OPDs in a college or medical hospital. So like this. Uh, then the actual case sheet. So actual case sheet is once again a detailed thing like this. These all you should mention in a proper case sheet. Same what you have been taught in MBBS. So pre-printed forms, that is what I do. It reduces the mentioning all these things. So quickly you can just fill up. And also what I do is I keep a strikeout system. Basic findings whichever are there, that is already written. All I do is I encircle and cut out the rest. So it reduces the writing time. So, and most important is not just the time saving. Many times when you're working at night, middle of the night, you're tired, exhausted, you're doing a 36-hour duty or whatever. And so when you're slow mentally, you forget those points. And later on, you don't remember, oh, I forgot to write that there were no, that I did mop count, but I forgot to write. So if all those is written in the form itself, then you do not have the fear. You just have to write and strike out. So then associated medical sheets. General admission consent, that is where the patient, you're taking permission that I will get admitted and I promise to pay the hospital bill, like that. Basic charts, vital charts, medicine chart, daily notes with time. This is very important. Just don't write date and write whatever notes. Time has to be mentioned when you are seeing. Treating physician or the team, anything, that is fine. But time has to be mentioned. Nurses' notes are separate. Investigations during hospital stay, what all you're doing, these are all not new for you because the system is usually there in most medical colleges. Now, with regards to this, additional consultation. So, if you are calling up a colleague or a senior, sir, ma'am, I have this case, what do I do? You send photos on WhatsApp and all. They tell you, okay, give this medicine. That has got no legal value. You have to come visit the patient, see, and then write. Telephonic opinion has got no legal value. Interdepartmental request written form what you're sending, that is fine. Procedure notes have to be detailed and not just summarization. It should be proper. And discharge card or transfer card, you should take a scanned copy along with the case sheet. This is an example of a interdepartmental consultation request. Probably you might be using this kind of form at your place also. Then procedure notes. So any procedure that you are doing, whether major or minor, must be noted in detail in the case sheet and not just a summary. So this is the main document of great scrutiny during court cases, and it is open to lot of interpretation by both medical and legal experts. For example, a simple hemorrhoidectomy. If you are writing like this, hemorrhoidectomy done under GA at so and so time, pile was removed, vital stable, no bleeding, intra uneventful, anal pack place. This is not acceptable. It should mention all these steps rather, whether it was emergency elective, indication of the surgery, type of anesthesia, what was just asked now, name of members of the surgical and anesthetist team, position of the patient, skin prep, rectal examination with proctoscopy findings. You have to note in the procedure note section, type of incision that you gave, then the specific steps, deepening of plane, lateralization. You all know these things. You're doing it on a daily basis. So, and then a similar step. So, whenever there is a bilateral kind of operation, so step one, like in hysterectomy, we are doing for one segment and then repeating the steps for the second segment. So, same was followed, not. You mentioned what was done on the other side as well, and whether you found any additions, unusual amount of bleeding. Most important is the surgical safety checklist. So their call in call out system is there. So over there, here too, count of surgical mops, swabs, what instrument used, and accounted for off the table, not on the patient's abdomen. It's there and still you're counting. Remove it and count and announce. So the announcement and the counting should be confirmed by one other member of the team, not just one person. Your scrub nurse is saying, ah, sir, all okay, sorry, sir, you can close up. No. There should be one more person who is cross counting with the person and announcing. Everybody should hear mop count okay, instrument count okay. This is very important. Repair and closure of layers and what material you used and type of dressing that you gave. End of surgery vitals. You're writing in post-op notes, that is different. But in procedure notes, at the end when you're finishing degloving, that time what were the vitals that you have to write. And in GA cases, obviously, how was the recovery? The last part is discharge and transfer card. So when you are discharging a patient, there should be a complete detailed summary. Probably you must be doing this already. So it should include the treatment and progress in the hospital and events during the hospital. Everything should be written in that. Similarly, a transfer card is such that same information, but you're transferring to a different center. So there too, all of this should be mentioned. And what is legally required is the reason for such a transfer. Like supposing we do not have this kind of facility, hence we are transferring. Or patient is critical, needs higher level of care, so that's why we are transferring. The reason for the transfer should be written. In the post discharge advice, you should be giving clear instruction for duration of rest or physical activity, when is it permissible, along with medicine and type of diet to be followed. If you have told the patient during hospital rounds, do not eat fried food, do not eat masala food, but you have not written, then that advice was never given. It's not only verbal, it should be written. When you're handing over the discharge card, in the case sheet, make them write discharge card received, because later on if they lose it, they may say doctor didn't tell us anything, no medicines for advice. So that's why take their acknowledgement. Now when you're writing a follow-up date, for example, uh, to visit OPD after 1 month for follow-up checkup, don't write just after 1 month. Even if they come after 6 months, still that is legally valid. So write a date, follow up after 1 month on 3rd March, like that. And so all the properties, medical records are actually the property of the patient. They can ask for the details even after discharge. By National Medical Commission, Rule 13B, you have to issue this within 5 working days. Previously, it was 3 working days. Now they have modified it to 5 working days. So Sunday is not a working day. medical information contained in the record cannot be disclosed to anyone without the consent of the patient. You can take a screenshot of this. This is the current guidelines that we are recommending based on all the national and I mean there are problem is there are no universal this thing how long to preserve OPD records, IPD records, medical legal cases. So these are based on all the recommendations that we are currently telling all doctors and all. So this is OPD is 3 years as per NMC. IPD is 3 years as per NMC, but if the hospital is under NABS, they are saying keep it 5 years. This is first thing. OT records, fumigation records, and autoclave register. These are all 2 years. So this is basic. Now there's a small concept known as period of limitation. Supposing you're doing a particular case, especially pediatric cases, period limitation is when the case is finished. Like today, you discharge the patient. Till how long can the patient file a court case against you? So that is known as 3 years. That's 3 years from the date of discharge, end of treatment. That is. But if the court feels so, they may allow the case even after that. Now, pediatric cases, this means that once the baby attains 18 years, from there the period of limitation starts. So any pediatric surgery that you're doing, just maintain the records for 21 years. After that, you can destroy. So it does not fall under the bracket of OPD and IPD records here. And retention period, what is mentioned here, can be higher than you want. You can keep everything for 7 years and destroy. Paper records you can destroy, but you have to give notice, small notice in the newspaper that medical records of this college, of this department from so and so date to so and so date will be destroyed after 2 months. Anybody who wants can come and take. So list like this. So who can access? Patient, police, court, doctors, government, and insurance companies. But for insurance company, they have to take a written request from the patient first and then access. They cannot directly send that my client was admitted there. Please give records. So this is the same thing. So yeah. Done.
Okay, Dr. Debrishi, I have a small doubt in
Yeah.
this. No, we see many times the attenders, they might be taking photos of our case files,
Not allowed.
and it is not allowed, even though it is not a medical legal case.
Doesn't matter.
So,
Until and
so
unless you give a written document or a summary or whatever discharge card, they cannot take. So inform all your staff that no attender should take photograph of the anything. Patient is under your care. If they have a question, they ask you first, not take the photographs themselves. If they want records, they can mention, and because non-validated record or a entry in the case sheet has got no meaning until and unless you have summarized, made meaning of it, and written properly. This is the legal rule.
one doubt is that let us say if you have we have seen the patient or we have done our rounds at 9 a.m. in the morning or
Right.
9:30, and our note, usually what I have noticed is most people put the notes 9:30 for all the patients. So
9:50.
at 9:30 for all the patients, because the
Okay.
round started at 9:30.
Right.
Is that acceptable, or is it supposed to be accurate timing? Like I
It
have seen
should
this
be
in
accurate timing. I'll tell you the two aspects. One is what is legally correct and what is practically we are doing. So practically you are saying that everybody is writing 9:30. The problem is if there is a court case and let's say at 9:30 you have seen and written for a patient, let's say hyoscine butyl bromide injection is prescribed, right? But uh, you have seen the case at 9 o'clock. Your note says 9:30. Nurse has given it at 9:20. So in the nurse's notes, treatment part, it is mentioned as 9:20 because you have actually seen at 9 o'clock. You have written,
Yeah.
nurse has given as per your order. So if it comes up to court, in your notes, it is the time is mentioned as 9:30, but nurse has given it at 9:20. So court will call the whole case sheet as rubbish. Just one mismatch. So if you are writing 9:30, tell the nurse to put the order time at after that. If that happens, that all night you're working, you're seeing the case at 9 o'clock and you're just writing 9:30 because you're supposed to see at 9:30. That is fine. As long as you've seen the patient, you can tell the nurses that order time is 9:30, but I'm seeing at 9 o'clock and going home or changing my shift. So in that case, now you're seeing at 9 o'clock, but you're putting notes of 12 o'clock. That is not acceptable. Little bit 5, 10, 30 minutes. That is fine. But order part should be same with you. It should not be different. Nurse order
Okay.
and doctor's order should be after, cannot be before.
My question was that can 2, 3 patients have the same note timing of the note? Like 9:30 this patient, 9:30 next
I
patient.
can't hear. I can't hear.
Can all the patients have the same timing in the notes? Because we have done the rounds at that time, like 9:30 notes of this patient, 9:30 this patient, 9:30. It has to be 9:35, 9:40, 9:45.
If there
That.
is a big case and the court orders the hospital to give all the patients records who were present on that day in that ward, then you're done for. How have you seen at 9:30 all the 50 patients in your unit? That means you have not seen. It questions our this thing. So you put it as 9:30, 31, 32 like that. It's fine.
Okay. Any questions regarding documentation for anybody? No questions, right? Okay. Um, okay. All right. End of surgery vitals. Okay. I think no more questions from our side.
Okay.
Um, so thank you very much for your for taking so much time and going into so much depth to teach us about little about law or medical legal aspects. So, and we hope that probably in the future, maybe we will get to discuss some more topics and we'll get to learn some more.
This subject is very dry and it is very boring. Puts you to sleep every time. Every time I read a case, I fall asleep. Even now. But then
Yeah,
once you start knowing a few terms and all of this is to safeguard ourselves. So you have to take time out from clinical part and learn about these things, and so that you can practice freely. You don't have worry. You're always scared if police comes to the door. Nothing. You have to be bold. You're working and saving lives. So act like it. Don't be scared of what is going to happen. But do the work properly. So thank
yeah,
you, everybody. I mean, you have
yeah,
listened
yeah.
patiently to such a boring thing.
No, I guess some other aspects like punishments and how to handle when a court case summons comes to you. Probably we can have some
Yeah.
other day. We can have a discussion.
This part, these three segments were the basic, especially the surgical cases part, because those are things you will face and you need to have clear idea about that. This is the basis. Go over it as many times and discuss among yourselves. If you have any doubt, you can always send me messages. I'll clear those doubt whenever required. And other segments which are needed for you, department specific, death on table,